Welcome to the Commonwealth Club. I'm George Hammond, Chair of the Humanities Forum, which organized tonight's event. We have a joint production between the Philip R. Lee Institute for Health Policy Studies at UCSF and the Lundberg Institute. This is the first of a series, apparently, that we were planning, right? And so that's what we're doing tonight. And I'd like to introduce Dr. Lundberg of the Lundberg Institute. He is the editor-in-chief of Cancer Commons. He is the editor-at-large for Medscape. He is a professor of clinical pathology at Northwestern, and he is the founder and chair and president of the Lundberg Institute. George, let's do it again.
Thank you very much, George Hammond, who has hosted us here for 16 years, once a year, collaboration between the Lundberg Institute and the Commonwealth Club. Welcome to those of you in the studio. We also have people online at this time, live. There will be a podcast posted in audio only on the Commonwealth site, Commonwealth Club site, and in a few days, YouTube will have the entire program on as well, all free. So I'd like to recognize some of our dignitaries. We have our treasurer, our CFO, Patty Lundberg. Would you wave from over there? She's a former English professor and dean back at Indiana, and she's director of our institute. And here we have Dr. Alan Green and Cheryl Green. Dr. Alan Green, they're directors of our institute, and Alan is well known for having been one of the founders of Internet Medicine, along with Bill Silberg, who just walked in. Hi, Bill. And myself and others. We invented Internet Medicine between 1995 and 1999. I'm serious. We really did. Anyway, Alan still has AskDrGreen.com, the most popular and best pediatric site. So they are some of our supporters from the beginning. The Lundberg Institute is dedicated to shared decision-making between doctors and patients informed by the best evidence. That's what we're all about, and we've been doing that for 16 years. Tonight, as indicated, we have a new collaboration. Dr. Alan Green worked with Dr. Joanne Spetz on stage to produce our first program of a collaboration between the renowned Philip R. Lee Institute of Health Policy Studies at UCSF and our little TLI, plus the Commonwealth Club. So we're looking forward to this being a good event, instructive, interesting, conflicted, and available to everybody free online after the event. We were expecting Claire Brindis. Are you here, Claire? Okay, well, she was the director of the Institute just before Joanne, and we're honored by her presence later on tonight as well. So that's it for me. Now we have Dr. Joanne Spetz on the stage, the director of the Philip R. Lee Institute, where she's been in charge for about 5 or 6 years. And she will introduce our speaker. Joanne?
Great, thank you. It's good to see people here. And as I was introduced, I'm Joanne Spetz. I'm the director of the Philip R. Lee Institute for Health Policy Studies. We have been around as an organization since 1972, and I have the honor of being the fourth director, the first being Philip R. Lee, who had served as the Assistant Secretary for Health in the Johnson administration, responsible for implementing Medicaid and Medicare. Very importantly, Phil believed that research was important and being a clinician was important, but you really needed to get on the ground with policymakers to have a true impact on people's health. And so he modeled that. He returned after his service in the Johnson administration to be the chancellor at UCSF. He then became the director of what started as the Health Policy Program and guided the Institute for quite a long time, including working very closely with the city through various public health crises, including the emergence of AIDS and HIV, and working on response to that, bringing evidence to practice, and various other guidance that he provided to policymakers at the local, state, and federal levels. So our mission overall is to advance better health for all people through evidence-informed policy, and we continue to follow the mission that Phil set of engaging actively with legislators, congresspeople, administrative staff at the state, local, and federal level, although lately I will say more state and local than federal. We have more than 200 affiliated faculty, about 30 affiliated fellows and trainees, and then dozens of research staff and communications and finance and other staff who are all active members of the community that we love to work with. Dr. Robert Hyatt, who I know as Bob, is one of our affiliated faculty and is our keynote speaker for tonight. He has a long career that you can read online, and if I tried to summarize it in much more than, kind of all the highlights would take up his full hour of time. So rather than do that, I'll just note a few specific things. He's an epidemiologist and a physician, trained in both areas, and has had remarkable impacts in both areas, practicing global epidemiology, domestic epidemiology, and research, and was served as the chair of the Department of Epidemiology and Biostatistics for 10 years, and has been an active member of the faculty of our Cancer Center. He continues to be a great partner and affiliate of IHPS, and also is always there for advice for me whenever I need it, since he has walked that ground of being a chair and a leader within UCSF ahead of me. So without further ado, I'm going to hand it over to Bob to give his talk.
Thank you. So, thank you very much, Joanne, Dr. Lundgren. I'm very pleased to be here and to be the first speaker in this joint collaboration between the Philip R. Lee Institute of Health Policy Studies and the Lundgren Institute. I'm very honored to be at the Commonwealth Club, having been a fan of the Commonwealth Club for years and years and years. The honor of actually being here physically is a treat. Usually I'm listening online, right? So congratulations to all of you that are actually here in person. So this is my topic for tonight. What diversity, equity, and inclusion mean for health science, and why big data is important for this whole endeavor. So this is what I'm going to talk about with you. First of all, I want to say why DEI is important in the work we do, some basic concepts about how we do research, and I'm going to speak as an epidemiologist in that sense. And then we'll go through these three words, diversity, equity, and inclusion, and what they mean to me and what I think they mean to a lot of people working in health sciences. So diversity can be translated into difference or variability. Equity is really a goal of our democracy, to seek equity. And one of the phrases that my community partners frequently use when they talk about inclusion is nothing about me without me. So that means when you're working with people of all sorts, they need to be part of the discussion. It needs to be a bi-directional discussion. And then I'm going to give you an example of a type of research that I've been intimately involved in for about 8 years called the Olivus Project. I think it's a very interesting example of big studies and actually big data. And then we will actually talk a little bit more about how big data and DEI interact, and some of the changes that have happened since Joanne has stopped being able to work with the federal government so closely as she was. So I'm an epidemiologist and an internist. Hello, Claire. And most people now know what epidemiology sounds like or is because of the epidemic. It's not a subspecialty of dermatology specializing in the epidermis. It's actually a long, very storied discipline within public health and medicine. And basically what we try to do is understand the causes and the distribution of diseases in populations in order to apply this knowledge to prevent disease. So we frequently talk about person, place, and time. Those three things sort of define the world that we work within. And the reason why that's interesting is because most of the work that we do actually is directly related to this combination of words that we're now talking about, diversity, equity, and inclusion. And I want to tell you why. So it's an important field, and it's one that, as I say, probably is more familiar to people following the COVID epidemic than before, because now they've heard it mentioned several times, and maybe they can even spell it. So that's my honor to be recognized in that way. So this is the perspective of an epidemiologist. For about 100 years, more than 100 years, medical scientists have been trying to understand how disease is distributed and how it works in populations, and not just individuals. I myself have also taken care of patients and people for a long time. So I'm interested actually in the combination of how you take care of individuals, but also with populations, and how dealing with populations helps you understand the individual that's presented to your clinic. Most human subject research, and this means research on people, not mice or other laboratory animals, was performed in easily accessible populations, people that were well enough and available to volunteer for research, sometimes schools, sometimes military individuals, sometimes prisoners, captive populations, if you will. And this led to problems with the results. It was a bias because these individuals that were captured in that way weren't representative of the population of the United States, or even the group that was supposed to benefit from the research. And this has gone along for a long time, and even with the revolution in genomics that has required, that had all the promise in the world to tell us about how to understand and treat disease, was limited because most of the data that geneticists and genomicists had was from white populations, very restricted group of individuals, mostly wealthy, mostly at the upper end of the socioeconomic spectrum. So it too was not representative, and it was recognized that more was needed there. So since that time, there have been lots of studies devoted to understanding a wider variety in the people in our society. Variety, difference. That's actually the thing that helps us understand where disease is coming from, when we can find something that is different, is out of the ordinary. I was taught as a young student in epidemiology that you could have an epidemic with one person, if that one person represented something that was unusual. So the idea of epidemiology is understand the difference between populations and the things that are out of the ordinary. So what do we need to move forward with this type of research? Well, we need to better understand the differences we observe in populations. So if you look around, and I'll show you some examples, disease and conditions of ill health are not evenly distributed. Each of you has your own experience with it. There are patterns of disease which need to be understood. And we need to understand more about the effect of the uneven distribution of resources that lead to some people being well off and others not. This concept of equity is really critical. And then finally, what we need is to make sure everybody benefits from the new discoveries. So that's my way of describing diversity, equity, and inclusion. Okay, these are the things we need to do in plain language. And they've been around for a long time, and they will continue to be motivating forces in what we do. So let's look at them each one after another. So diversity. Diseases or conditions, as I've said, that cause illness or death are not evenly distributed in any population. We observe lots of different patterns of disease. Right now, we're seeing a lot of measles in Arizona. What's that about? Why is it only in Arizona? What is measles? Probably most of you in the audience have never seen measles. How many people in the audience have seen measles? Yeah, okay, everybody with gray hair has. And breast cancer is something I've studied for decades. We observe more breast cancer in white women and white women of upper socioeconomic status. And what is that about? Why should women who are basically well off be more susceptible to that? That's a pattern, that's a difference that helps us begin questions. And then finally, when we started seeing the evolution of the COVID epidemic, we realized that it was affecting mainly blacks and Latinos. And again, it was a difference. It was a pattern that we needed to understand. So we need to understand the causes of these differences in order to do something about it. So a lot of people would think that epidemiology or this type of population science is basically to understand cause, not just association, but cause. And if you can understand a causal relationship, then at least theoretically you can do something about it. So what we were about is preventing disease, providing earlier diagnosis and effective treatments, and that's what we can do if we have understanding of diversity. So a couple of things about different patterns of disease. So you can guess what this is. Dr. Hammond, do you know what that is? Measles, right. So most people practicing these days have never seen measles. It was really under control and really no longer a public health problem. But nowadays we're seeing measles develop in certain areas of the country, in certain areas of the world. Largely, we think, because of lack of vaccination and public health practices that have been in place for many years. So here we have an epidemiologic observation of difference and of place. And the question then becomes, why is this? What's happening in Arizona and New Mexico? Part of this is because of the American Indian populations there that have not been vaccinated. And part of it is due to the lack of vaccination in populations more generally. But my point is that by making observations, we see differences, and then that leads to the need to understand what's causing the difference in order to do something about it. This is a very famous picture or figure. It takes us back from current times to the middle of the 19th century, and there was a man named John Snow, who was a scientist and an observer of the human condition, let's say. And he was interested in why cholera in London was affecting certain people and not others. And so he set about to map where the cases of cholera were coming from. And this is a map of London with the black spots showing where the cases were located. And he was able then, once he saw the difference in where people were living, to come up with a hypothesis that the reason for this was that they were all using, where were they getting their water? And in those days, people would frequently get water not from their tap, but from going to a local pump in their neighborhood, pumping the water and bringing it back home. And the water that these people were getting came from a water company that was pulling water from the Thames River very close to London itself. And people who had water coming from another company that were pulling the water from further up the river where it wasn't so contaminated were not getting cholera. So this led him to, from making an observation of difference, to a hypothesis about actually what turned out to be germ theory. This was before they knew about cholera as a bacteria. This was a cartoon from the time. This is the Broad Street pump, as the famous story goes. But people who used this pump were the ones that were getting cholera, which, as many of you probably don't know, was a very fatal disease. It led to rapid dehydration and death within days in some people. So again, observing a difference, understanding location was critical to coming up with a solution. Legend has it that his solution was removing the handle from the Broad Street pump, which may or may not be the only thing that happened, but anyway, that's out there as part of the story. What about equity? So in this country, we generally accept the idea that everybody is born equal, created equal, and that we should have the same opportunities to succeed. That's how we live in a democracy and in this country. However, social hierarchies do exist, and we work to minimize them, not always successfully. And for example, there's ample evidence that income inequality is associated with health and disease. And studying these differences has allowed us to generate ideas for changes in health policy and public health interventions. I'll show you a couple slides that illustrate this. So this is the way we think about equity and equality. So equality is when everybody has the same box, same size resource, okay? Equity, however, is when everybody uses those resources to achieve the same, in this case, view of the game. The ultimate thing, though, is to take down the fence, which is a structural problem. And then everybody has both equity and opportunities. This is a slide that's used to teach about equity and equality in schools a lot, and so I thought I'd share that with you. This is another thing which is used a lot, and it's called the Lorenz curve, or the Gini coefficient. And it plots a cumulative percentage of total income against the percentage of the total population. I'm wondering if there's a pointer in this thing. Okay. I have a pointer with me. So if everything is equal, then you find people distributed along the diagonal. But as inequality sets in terms of income, the curve goes to the right. So if you look at the B curve, for example, at 80% of the population is only having 20% of the income. And that is income inequality. And you can actually use the Gini coefficient as a metric, as a quantitative metric for understanding income inequality. So a couple of slides to show what that looks like around the world and around our country. So this is a slide looking at life expectancy by the Gini coefficient. And you can see that the right-hand side, they've pulled out Sweden as a place where life expectancy is around 83 years. And on the other, and the Gini coefficient is very low, meaning it's very close to that line. Whereas countries like Colombia have a very low life expectancy, around 73, 10 years earlier, and their Gini coefficient's very high. In the United States, it's not great. It's right in the middle. So we could be doing a lot better. and part of that are things associated with income inequality. If you look within our country, the same sort of correlation exists. Hawaii, on the right-hand side, has a life expectancy of over 81 years, but people living in Mississippi are under 75 years of life expectancy. And the correlation with the Gini coefficient is again there. It's not as strong, but it's still there. The other thing you can tell from collecting information on different types of people is when we do that with people from different race and ethnic backgrounds, different ancestry. And so this is an example of hospitalization rates with COVID with different race ethnic groups. And you can see the marked difference between, in this case, American Indians and blacks and Hispanics with whites and Asians. And if we didn't, my point here is that if we didn't have this kind of data on differences, we wouldn't be able to recognize these phenomena that we can do something about if once we understand it. Okay, and then there's inclusion. So what's important about inclusion? Well, we need to have wider representation of everybody in society in order that the results of our research, health science research, can be applicable to them. 50 years ago, when I started doing research, it was commonly done on white men who were willing to volunteer. We didn't think much of it. It was just the way it was done. And it meant that the research results then were not always relevant to other members of society, right? Because it was a limited sample that was being studied. I was around in 1991 when Dr. Bernadine Healy became the director of the NIH, and she decided to do something about that to change the assumption that men were the default patient. And she started something called the Women's Health Initiative. And the Women's Health Initiative gave us a chance to look not just at men in our studies, but women as well. And that was where the Women's Health Initiative started, which generated all sorts of really critical information about the use of estrogen and calcium and breast cancer and heart disease in women that had not been understood before because of the focus on men. So inclusion, in this case, of women in studies. This is something we're doing in San Francisco, where we're including as many people from San Francisco as we can. These are data from the Cancer Registry. And what I want to point out is that the line on top is the line for non-Hispanic blacks and prostate cancer. Now look at that difference, huge difference between blacks and the rest of the population. And if we didn't include the individuals from all of our society, we wouldn't understand this difference and wouldn't be able to do something about it. So again, inclusion is a critical part of what we need in our research. So what about the All of Us program? This is something that I've been the principal investigator for at UCSF for the last 6 or 7 years. It was developed under the Precision Medicine Initiative that was funded by the 21st Century Cures Act under the Obama administration. Initial funding was $130 million per year, and that has basically continued for a goodly part of the time. The goal was to recruit 1 million people around the country from all walks of life, all the variability that we know exists that has not been captured by traditional studies. Participants only had to be over 18 and able to speak English or French, English or Spanish in order to sign the informed consent and understand it. Otherwise, everybody's eligible from all walks of life. And this slide, which is one of theirs, gives you a sense of the variety that the study was looking for. So the All of Us research program is really historic. It's longitudinal, meaning it's following people over time, trying to get 100 1 million people, and taking into account differences in lifestyle, socioeconomics, environment, and biology. And we, we hope that the researchers are working on this will be able to understand individual risk more precisely, which leads or supports the idea of precision medicine. So the All of Us research program is part of the broader precision medicine initiative. These are the kinds of things that you can get when you look at a big data set like that. These are just some of the questions that might arise, but there are hundreds, thousands of questions that have risen to look at this data, and there are people all around the country now that are using this data, and it's been available since early times to answer important questions. So the innovative aspects are the people, the health status, the different types of data, and the geography. So the differences in the diversity is something observed in 1 million people. There are also diversity of data types. So we did physical examinations, collected blood and urine, asked a lot of questions about behavior and background, medical histories. And the participants are partners, so they are co-investigating problems with the researchers. So it's citizen science, or understanding what people are really concerned about. And it's become a resource. So participation is open to all, no restrictions, no bias in participation. It reflects the diversity of our country. A lot of trust being generated because it's so open. Very protected data. And this is where we are as of this month. So we don't have 1 million people, and we probably won't because it's been defunded now. But almost 900,000 people on the way toward 1 million. And almost 600,000 have fully enrolled, which means they've filled out all the questionnaires, they've been examined, they've given their blood, their urine, and we have detailed whole genome sequencing on them. So huge amounts of data, even on one person. And then you multiply that times the number of people who are participating. And 80% of the people are underrepresented in medicine in some way. Now, it's not just race and ethnicity, but there are people with disabilities, with language problems, with learning problems, old people that are not part of some of us with white hair, for example, don't usually participate in these kinds of things as actively, and others. So it's really quite diverse. Differences can be observed in this study population, as I said, and they're included in the research. There's over 1,000 registered institutions and almost 22,000 investigators working on the data already. So every month I get an opportunity to see who's working at UCSF on the data and prove their participation and so forth. And there's hundreds and hundreds of people just right here locally. So let me say some things about big data. So big data is usually spoken of in 4 different ways. It's large volumes of data available at high velocity with a lot of certainty or ability to ascertain the quality of the data, and variety. Now, if I had my pointer, I could point to the people logos up there. But the point is that big data benefits also from diversity in the populations we're studying. So we're actually not talking about big data as much as we used to using that term. Nowadays, we're talking about artificial intelligence and large language models, because that's how you get at the value of big data. And we're able to do that because we have very large data sets now from questionnaires, from genomics, from electronic health records, which is sometimes referred to as real-world data, meaning it's not part of a randomized study where there's a lot of control about who participates, but this is reflecting what's really happening in our population. It also includes environmental data, and it's a source for all of us. Is a source for all of this. Interestingly, this new technology and approach to science has caused some switch from deductive to inductive reasoning. So it used to be when we looked at a problem, we would develop a hypothesis and then look at the data to see if we could prove or disprove the hypothesis. Now, instead of coming up with a hypothesis at the beginning, artificial intelligence and machine learning is allowing us to look at huge amounts of data and seeing what it tells us, seeing where the messages come, seeing where the signals are, and then developing a hypothesis around that that can be then tested. So we're using these new tools to look at a lot of important diseases. And guess what? We're looking at diversity in the population. We're able to study it because it includes a good representation of everybody in the country. And we hope that it's going to be used to reach equity more rapidly in our population. So let me finish by saying something about what's happened in the last couple of years. Because of changes in policy at the federal level that have been critical of DEI, a lot of the projects that we have been doing in an ongoing way have been defunded or paused. Some of them have been refunded later. But it's been really disruptive in the sense that new proposals have had to delete language that we have been using for years, or we have to modify it in some way to make the proposals and the reports more acceptable. And we've had to avoid or modified language that relates to DEI. And this really can, I don't know if you think so, but to me, a lot of it's ridiculous. We can't use words like gender or oppression or climate change or racism because they are flagged as being indicative of DEI, which is considered a expensive and racist approach to finding science. And I hope that what I have said shows that the reason and the way we've used diversity, equity, and inclusion has been because it's consistent with the basis for how we understand research, especially with epidemiology, and why we hope to persist. So the consequences of these changes have been fairly drastic and hard to deal with. As chairs of departments and leaders in medicine. So what I'm calling population health or epidemiology, or anything that's dealing with large populations, has been severely constrained. Investigators all across the board are disheartened because their research is being pulled or defunded, and new investigators are frustrated and don't know where to turn. They're demoralized because they're not sure what their future is going to look like. And then we're not also able to collaborate with international colleagues as much as we used to. So I won't say anything more about that, but I think Joanne would back me up that it's been really a devastating, had a devastating impact on our teaching and our research that we're performing. And all we're trying to do is understand differences, how to reach equity, and how to include everybody in the process. So I'll conclude just by these statements. We've had a focus on observed differences, diversity, aspirations for equal treatment of all citizens, equity, and the inclusion of all types of real-world participants in research, inclusion. And this has been true for a long time, and we will continue to do that. The application of these principles to major scientific initiatives have been successful and made significant contributions. In many ways, all of this is one example, but there are many other large data sets and large approaches. I mean, larger scale approaches that have been very successful in advancing science. So, that's where we are, and we're not sure what the next steps are going to come, where they're going to come. But these principles are age-old in health science. They've been around for a long time, and they're sound scientific principles, no matter what you call it. And we're really hopeful that the future is brighter in terms of the acceptability of how we're approaching science. Thank you very much. I'm happy to answer any questions. Yes, sir.
Hang on one second. I've got a mic. Yeah. There you go.
Has all of us given any insight on the relationship of the transformation of food to being ultra-processed and the obesity, type 2 diabetes epidemic?
Well, yes and no. I mean, so the way we get that information is through examining people, and we have information on height, weight, therefore body mass index, and we have minimal information on diet and its contents. So there's a sub-study being done, which is capturing more data on diet in great depth, I would say, to answer some of these kind of questions. And the questions there are capturing ultra-processed foods, but it's only in a subset. I say only, but it's a large subset of the total population. So that illustrates another aspect. So the answer to your question is, limited to that thing, but it's nevertheless happening in that subset. But the overall platform of all of us allows us to have these sub-studies to look at nutrition, substance abuse, eye problems in more depth. Thank you for the question.
What about the apps that are now available using artificial intelligence that you can just take a picture of what you're about to eat, and when when your soup or something that's not apparent, you can quickly put in what you're eating and have a pretty good representation over time.
Yes, that's a new way of ascertaining what people are eating. We used to rely on other methods of food frequency questionnaires. How often have you had broccoli this last week, for example? Or 24-hour recall. What have you eaten in the last 24 hours? And sometimes metabolic units where you capture what people are actually eating in a very measured way. But what you're mentioning is a new way of using visual ascertainment and AI to capture the contents. That's not what's going on in all of us, but it's an important way of gathering information. Thank you.
Yeah, I'll add on that we have a visiting fellow from Singapore who is a Harkness fellow, and she is working with exactly that kind of app to develop apps that then can help provide some coaching or some guidance of like, maybe you could increase the portion of vegetables on that plate you just photographed here, without being heavy-handed with it, but trying to get that, kind of hit that behavior nudge with the photographic approaches. But then, of course, on the back end, they're getting a big database.
Other questions?
I like the angle that you're going at there, looking for a PR, point that can be done for the national government, of how can you sell this idea back to them and make them like it. And I was thinking the same thing is for DEI and how it got started in universities and everything, going way back to the time of Andrew Jackson. He's one of his favorites. And we could just say this was started at the time of Andrew Jackson, and it has nothing to do with any of the issues that you're concerned about. It's a broad-based thing. So we need PR people working on his interests and how to sell it. Another question.
Because of the bright lights, I can't see hands up, so
I'm interested in how the university is trying to accommodate the lack of federal funding until better days come along.
important question. I think pretty well, because when people lose their funding, the university has come up with bridge funding, let's say, until better days are available. But some people are just losing their funding and have to find other ways to support themselves and support their research. So we're losing young people who are trying to do a dissertation because they're no longer able to get that research funded. So it's not an easy solution. The university is stretched to accommodate some of the people that are already in the process of almost completing their doctoral degree, for example, but others are just not able to finish. Joanne, do you have some other thoughts on that?
Yeah, the last data that I saw showed that the total dollars of research funding that came in by the time the fiscal year was over last year was about the same as it was the year before, which was a pleasant surprise. Now, a lot of it came in at the end of the fiscal year because there were so many delays in the first part, which meant everybody was on pins and needles. But they did change some mechanisms so that they're doing what people are calling multi-year awards. So there were fewer grants made for the same dollar amount of money. And some of those grants were made to people who were already more established, leaving some of the earlier stage people kind of in the cold. And there are other kinds of funding mechanisms. Like for us, we have a training grant from the Agency for Healthcare Research and Quality. That's a really small little agency, but they basically study everything that Americans complain about the healthcare system. When people talk about how much it costs, how fragmented it is, how difficult it is to find a primary care provider because there seems to be a shortage of them, that's the kind of thing that ARC studies. But for some reason, the White House thinks it should be defunded. Congress did fund it, but we didn't get our training money last July. We had 2 fellows. So how do we keep our fellows? We made a donor appeal and we had donors fill up the fund. So we were able to not lay off our 2 postdocs, one of whom is doing substance use research. The other is doing research on food security. And so, highly important issues that we know affect people's health quite broadly and affect a lot of personal households pretty deeply. This year, I haven't been able to make an offer to a postdoc yet because even though Congress put the money in the current budget, I don't know if we're ever going to get it. So I've been holding off. Every time somebody writes to me and says, "Hi, I'm wondering where you're at because I have another offer," I'm like, I am so glad you have another offer. Go take that offer. Go do your thing because of all that uncertainty. And we don't know where it's going to go in the future. I know the other piece that the university is worried about is the Medicaid cuts that are coming. It's a little bit of a sleeper issue, but the big BBB, the HR1 that was passed, that some of us don't think was beautiful, had significant cuts to Medicaid in it, but those cuts don't take place until after the midterm elections. So,
Why do you think that is?
Why do you think that is, right? Because, it actually is going to fairly disproportionately hit some of the southeastern states and other areas and rural areas where people do tend to predominantly vote Republican, right? It's going to hit those areas disproportionately. I know our medical center is worried about that. UCSF is a public institution. We are a tertiary medical center. So if there is a 26-week premature baby, that is what we do. We will take care of that baby because we view ourselves, we're not quite San Francisco General, but we also staff San Francisco General in the medical fields. So we are worried, and there are higher powers than me in the institution that are really trying to figure out what that is going to look like. But the big picture is that we're still going to provide the care. We have to figure out how we're going to pay for it. And that effect on the clinical revenue and the money that's coming in from that is probably going to then impact some of these backup funds and bridge funds that we have available for the research gaps. So I do not envy our chancellor and our president of UCSF Health, but I also have a lot of trust that they're really being thoughtful and being very proactive in thinking about how we are going to weather these changes when they hit in about a year from now.
Thank you for the question. Yes. Dr. Brindis.
Thank you. Thanks, Bob. Nice talk, capturing many, many important themes in your life, your very productive life. And I'd like you to talk a little bit about this whole last mile, the concept of using evidence to develop initiatives and implementation science. And maybe you might want to speak from all of your experience in breast cancer. I think that people, especially the new director of NIH, has expressed that we're tired of just gathering more information on the fact that there are different patterns of people. We want to have action. We want to implement solutions. So could you give a few real-life examples, perhaps from your own research?
Yeah, this is really important. And I think some of my slides said the reason why we're doing this, to understand difference and inclusion and inequity, is in order to do something about it, to establish interventions, programs that can really make a difference. And this brings us into the area of implementation science, the last mile, if you will. What happens when you finish a discovery project where you learn about difference, for example. And it used to be that academics would write a paper and get it published, and as they say, put it on the shelf, and it would gather dust and never have an impact. We've gotten wise to that in the last couple of decades, and we know that in order for the research we do to have an impact on populations, we have to take it to the extra mile. We have to go into ways and understand ways to implement the science and make a difference. So there's a whole field now called implementation science, or diffusion and dissemination research. And a lot of people are getting into that because they realize how important it is to really try to use it to make a difference. One of the challenges is that the people that are trying to do this have so far been trained traditionally in medical research and are not very savvy about how to work with labor unions, with teachers, with other aspects of society to make change happen. So that's part of what we're trying to do with implementation science, is we're working with, I think in the case of the Institute, with the law school here locally to understand the impact that they can have with understanding laws and regulations better. But also, political science and sociology and anthropology. All these sciences our disciplines become important for us to work with in order to know how to create change. So it's not just what we do in medicine or health sciences, it's how we can work with other disciplines. It's something which is called transdisciplinary research, which is basically identifying a problem and finding ways to work with other disciplines who may have a different perspective on the same problem in order to come up with a solution.
Yep. I'll make a big pitch for the social sciences there. I'm an economist by training. I'm not a clinician. Do not ask me to look at the thing on your skin or whatever. But my training is follow the money. And so sometimes if you say like, gee, we know from a whole body of research that people who have high genetic risk for breast cancer, mammograms are not great screening for them. When they're young and they're more likely to get those genetically associated breast cancers that are really aggressive. They're young, their breast tissue is dense. Mammograms are like a sea of white. You can't really see anything. And so I think it's about 20 years ago, 15 years ago, it started becoming really clear for this group of people with these genetic markers, you should be doing MRIs of the breast, and that's the right answer. And then it's well, at what age? And MRIs are expensive, and how many people should get them, and so on. So there are some economists that took to it. I remember I was working on it with a colleague here at UCSF, and somebody at Stanford scooped us, and we were like, darn, but hey, at least somebody got it done and documented kind of this was a cost-effective approach, when should you do it? But now what's the next step? You have to get insurance to reimburse it. Because if insurance isn't going to reimburse it, then the clinics and the practices aren't going to do the radiology and spend the extra money on it. And that's the implementation science piece, where it's okay, now it's reimbursed, but you go to a clinic and the doctors haven't heard about this because there was somebody in the back office who got the new reimbursement rate and didn't tell them. Or they didn't do it because they haven't quite figured out how to work it into their workflow. Or, the mammogram, I know where that is, but I'm not sure where the best MRI imaging is going to be for this. So there's a knowledge gap that they need. Those are all things that really get into the social sciences.
Exactly.
And are exactly what Bob was talking about, why it's actually really complicated to do the implementation. And that's becoming in and of itself its own scientific field. And the Department of Epi and Biostats has a master's degree program in it now.
Okay. So just to get back to your question, two things to say in addition. One is that there are now efforts to be more precise in screening for breast cancer. So the Wisdom study, which I'm sure you know and maybe others do in the audience, is trying to understand risk, not just based on age or a previous mammogram, but based on genetic signals and on MRI and other more detailed information. And we've now developed something called a polygenetic risk score that looks at less penetrant genes that are still abnormal, putting them all together into a risk score. So there's newer ways of being more precise about approaching the individual based on what we know about differences in people and how to approach it. That's one thing. The other thing is my own experience has been with populations. So I lead something called the San Francisco Cancer Initiative, which we are using to tackle the problem of cancer in general in San Francisco. Can we reduce the frequency of cancer in San Francisco, where it's the second most frequent cause of disease and mortality? We call it SF CAN, because we believe that SF can do this. And so we're working with community groups and not-for-profit organizations to try to implement the work that we've done in research on in the community. So community clinics, health fairs, other types of contact we have with community members, where we're, again, working with them as partners. So that's another type of implementation, another type of extension of what we have not been trained to do, by the way, but where we see it's really important for us to go the extra mile, to take some steps away from our comfort zone in medicine, our channel, if you will. So I recently wrote something that said, it's important to leave your channel to get some things done. And that's one of the ways that that's done. So thank you for that question. Sir.
So we're talking about policy studies, and I wonder if you had hopes or fears or both about the new potential Surgeon General, Casey Means, and her boss, I guess, or colleague, Robert F. Kennedy Jr. Not so much about the vaccinations, but about the Make America Healthy Again. What are your thoughts about those?
Well, you're inviting me to head into politics here. And it's fun to do that maybe, but I would like to try to stick with the science and what I think it can do. My feeling about both of those individuals is if they follow scientific principles and stick to the way we do science well, that there'll be good outcomes. But I think there's ideology that's interspersed with their approach to gathering new knowledge, which makes it more difficult. Yes?
Having watched this thing evolve for a long time, it seemed to me like the grievances that resulted in Project 2025 on the whole issue of equity, fairness, et cetera, largely stemmed from perceived failures of merit being used for applications for college, for medical school, and for jobs. And that when that got stated as, well, that's a DEI issue, it sloughed over into the words and slopped over into NIH grants and CDC issues and how do you figure out a vaccine study and on and on. And so I think it got it trapped with all those words that were really aimed at things that I can't get a job. Somebody else got my job, somebody else got in school, whatever, rather than not studying diseases and understanding diseases better. I think a lot of it was simply an off the track, possibly unintended consequence, but a very serious one. Although, fortunately, as you pointed out, the Congress has recognized it's not quite there, and there's funding, but there's still a lot of problems in terms of funding. So, thank you.
You used that term slop. It was like AI slop maybe here on.
Excuse me for sitting down, but I mean, I needed to.
The chair was for you.
Okay. I've been used to chairs.
Are recent factors such as weight loss drugs or the increase of smoking in young people affecting long-term data sets that have been going on for a large amount of time, as you mentioned, like the All of Us campaign that started in 2015? Is that creating complications in understanding cancer rates and obesity rates?
Well, that's a good question, and the answer is no, because when we're studying populations longitudinally, all sorts of things happen to them. They change. And we have statistical techniques to assess the impact of GLP weight loss drugs for the time that they're being used in a period of time that we're following somebody. So there are ways of looking at that, but they have to take it into account. But that's if you will, the beauty of real-world data is that this is really what's happening with people, as opposed to a metabolic ward where you control what they eat very, very strictly over time. So this is observational data, and you have to find ways of understanding cause from observations, which we do in epidemiology. So yeah, those things have certainly altered the picture in terms of what we collect. I'm working on a project now to study liver disease, fatty liver disease, which is associated with obesity and becoming much more common. The reason why it's important is because it's a precursor to a lot of liver cancer and other gastrointestinal cancers. That's my interest as a cancer epidemiologist. But so we're using data, big data from Kaiser and from the VA. And guess what? We have to take into account the use of GLP medicines that have begun during the time that we're following them up and will have some effect on the outcome. So a very insightful observation, and we're on to it, so to speak. It makes it difficult, but it's still being done.
We have time for one more question. Somebody have another question? Okay, well, I do. You mentioned something,
Yeah.
which I found surprising, which was that an epidemic can have just one person in it.
Yeah.
Yeah, would you explain that? It seems like epidemic means that it's hit a lot of people. I understand that you said that the person had some special variation or something.
It's really a teaching point, but it's meant to say that epidemics are when something unusual happens. So, we're used to following influenza and seeing when it peaks in certain months of the year, or COVID and so forth. But for some parasitic diseases, which are not endemic, having one case can be considered an epidemic by the definition of an epidemic. It's not, frankly, very useful in a public health way, but it's meant to make the point that what we try to understand are differences and perturbations in what's sort of a background story.
Then one last comment. So we almost didn't talk about COVID at all today. You mentioned it a couple times, but not really much. That was the most recent big epidemic,
Right.
that everybody got excited about. Does that mean that it's almost over, or it's becoming a routine common cold, or
Well, I think
how come
it's
not pay
more like
attention to
that.
it
I think
anymore?
it's more like the routine common cold. This last year, more people died from influenza than died from COVID. So it's out there, and it keeps mutating, and we have to keep getting vaccinated against the most recent strain. But it's not causing the stress on the medical system that it used to, where we had people on respirators and couldn't find enough respirators to keep them alive. I think the beginning of the epidemic was an illustration of how fragile our medical system can be when it's stressed like that. So there were places in the country, as you know, that just couldn't deal with the amount of severe disease and mortality that was associated with the new introduction of this infection. So we've learned to think about things in a more planning way ahead of time, try to get ready for the next one. There's a lot of efforts now trying to get ready for the next big epidemic, which will probably come.
Since you're an epidemiologist,
Yes.
do you feel that epidemics are kind of generous in this way, that they start big and then they keep adapting until they just become part of our lives? I mean, it seems like, why would it go that way? It should, maybe everybody in the movies and everything, they start big and then they take us over and wipe us out.
Yeah.
So,
Well, there's there's something called the epidemic curve, and that's basically where you track the cases of a disease or condition, and it peaks and then usually drops down. And epidemics do have a natural history, and some reasons why it's heading downward are because of control measures that have been instituted. Others are when the susceptible population is exhausted and no new cases happen. So sort of tongue-in-cheek, a comment on that phenomena is that a lot of epidemiologists get on the curve when it's going down, ride it downward, and then they say, "Okay, see how successful we were with the treatment." Yeah, no, that is true. That is true. It has, most epidemics that we see have a course, and the reason why they're interrupted can be because of us being smart, and others because it just runs out of juice.
yeah. Well, it's always nice when we're smarter than
Yeah.
they still have the juice, right?
Right.
One last question from someone? Great. Well, thank you very much, Doctor. That was great. So I'd like to thank the Philip R. Lee Institute for Health Policy Studies and the Lundberg Institute for putting this together for us at the Commonwealth Club. We hope you all got a lot of good information from it, and we hope to see you again at other programs. Thank you very much. And so ends another program in the 124th year of enlightened discussion at the Commonwealth Club World Affairs. Thank you very much.